everyone, this is Dr. Garima, one of the mentors of StudyMEDIC, and today we'll be discussing about important concepts on post-op care module. So we'll start with the topic on abdominal incisions and sutures in obstetrics and gynecology. So abdominal incisions, we have transverse incision, vertical incision and oblique incisions. So amongst the transverse incision, the most commonly used are Joel Cohen and Fannin steel. Fannin steel is 10 to 15 cm long and 2 cm above the pubic symphysis, while Joel Cohen is 3 cm below the level of ASIS and it is higher than the level of Fannin steel incision. For the purpose of cesarean section or abdominal surgeries, Joel Cohen is considered better than Fannin steel incision. Why? Because it has less post-operative febrile morbidity, less analgesia requirements, shorter operating time, less intraoperative blood loss, and less chances of adhesion formation and reduced hospital stay and in wound infection. The transverse incisions include Maillard incision, which is a muscle cutting incision. You can see it is quite high up. In this, all the layers of the lower abdominal wall are incised transversely, approximately 3 to 8 cm above the symphysis, depending on the patient's habitus and indications for the surgery. Then there is a Czerny's incision. For this, there is another exam-tested question that it is used for Bursch-Kolper suspension and tape procedures. It involves transection of rectus muscles at their insertion on the pubic symphysis and retraction keflad to improve the exposure. This can be used for urinary incontinence like Bursch-Kolper suspension and tape procedures to access the space of Retzius and to gain exposure to the pelvic side wall for the hypogastric artery ligation. So this is the Czerny's incision. Then what are the advantages and disadvantages of transverse and vertical incisions? So transverse incision, they have better cosmetic results, they're less painful, less interference with post-op respirations, greater strength. Disadvantage, they are more hemorrhagic, more time consuming, and they result in potential spaces with hematoma or seroma formation. Disadvantages of vertical incision. So vertical could be midline, upper midline, lower midline or paramedian, right or left paramedian incision. There is excellent exposure with these. These are easily extendable. Median incision is less hemorrhagic. There is minimum nerve damage and rapid entry into the abdomen. Disadvantages include wound dehiscence and hernia, poor cosmetic results. There is higher rate of infection, hemorrhage, and operative time with paramedian incisions. Then the next topic that we will be covering is on SSI and enhanced recovery. Surgical site infection or SSI, it is defined as an infection, a superficial or deep skin incision or an organ or space occurring up to 30 days after the surgery if there is no implant and left behind or within if the implant is there then 1 year. And the most common organisms causing this includes Enterobacteriation Staph aureus. Most common of these is Enterobacteriaceae accounting for 30.2% and Staph aureus accounting for 22.9%. Now these are divided into superficial SSI, deep incisional SSI or organ space SSI. Superficial includes those involving skin and subcutaneous tissue. Deep include involving deep soft tissue and organ space involving organ space. Now, there are certain measures which can be taken in the preoperative, intraoperative and post-operative period in order to reduce these SSI. They start with nasal decolonization. The NICE recommendations for nasal decolonization state that decolonization with mupirocin, which should depend on the type of the surgery and the patient factors such as their MRSA status, and it is considered a good practice to screen for MRSA and to decontaminate women who are undergoing surgery. Then regarding preoperative bathing, it is a good idea to take bath with soap or an antiseptic agent on the night before the surgery or on the day of the surgery. Regarding hair removal, ideally the NICE discourages routine preoperative hair removal because it is not considered cost effective and does not prevent SSI. However, NICE advises that if hair removal is at all necessary, it should be done using electric clippers. Then regarding antimicrobial prophylaxis for cesarean section or hysterectomy, it is recommended that routine antibiotic should be given prior to starting the cesarean. But if augmentin is to be used, it should be given only after cord clamping because it is associated with necrotizing enterocolitis risk. Regarding redosage, for these antibiotic prophylaxis, the recommendations state that redosing can be considered in case the surgery is prolonged, that is, if it is more than 3 hours or the blood loss is more than 1.5 liter. For morbidly obese women, consideration should be given to administering a high or indeed a double than the standard dose of prophylactic antibiotics. Regarding vaginal cleansing, it is recommended that you can do cleansing with 4% chlorhexidine gluconate or povidone iodine before hysterectomy or vaginal surgeries. Then, if you see what are the recommended antibiotic prophylaxis, for most of the surgeries, it is a combination of cephalosporin and metronidazole, except if it is MRSA positive, where you give teicoplanin and gentamicin. And in case the patient is penicillin allergic, then you go for clendagenta. Regarding intraoperative phase, for hand decontamination, for the first operation, antiseptic solution and single-use nail brush should be used before the first operation. And for the subsequent operation, antiseptic surgical solution or an alcoholic hand rub and hand rubbing or scrubbing should be done for a minimum period of 3 minutes. Regarding incised drapes, it is a good practice to use iodophore impregnated incised drapes unless the patient is allergic to iodine. And in case you're using non-iodophore impregnated ones, the risk of SSI is more. Regarding skin preparation, NICE recommends that you should ideally use as a first choice alcohol-based chlorhexidine. However, if the surgery is next to the mucous membrane, you can use aqueous solution of chlorhexidine. And in cases where chlorhexidine is contraindicated, you can go for aqueous or alcohol-based solution of povidone iodine. And chlorhexidine alcohol should be applied using gentle back and forth strokes for 2 minutes. This you have to remember, it has to be applied for 2 minutes for moist sites like inguinal fold and vulva and 30 seconds for dry sites like abdomen, and it should be allowed to dry for 3 minutes. NICE recommends skin preparation and alcohol-based chlorhexidine before skin incision and therefore ensuring that alcohol-based solutions they dry by evaporation if diathermy is used. Then, regarding skin incision, Joel Cohen has already discussed is better than fan and steel because it is associated with less post-op pain, fever, analgesic requirement and blood loss, as well as shorter operating time and hospital stay. Regarding negative pressure wound therapy, it is recommended by NICE wound management technique in which a vacuum dressing is applied to promote wound healing. A seal wound dressing is attached to a pump which creates a negative pressure environment in the wound, increases the blood flow to the area and draws out excess fluid from the wound. It allows for continuous negative pressure of 80 to 125 mm of mercury over 5 to 7 day period and allows for even distribution of pressure over the wound. It stimulates formulation of granulation tissue, increases the blood flow, reduces edema and improves wound contraction and protects against external contamination. Regarding closure, you can close the uterus in either 1 or 2 layers. There is no difference in the rates of SSI or endometritis. Subcutaneous tissue closure is beneficial only if the fat is more than 2 cm. And ideally, it is always better to use antimicrobial coated sutures like triclosan, which reduces the risk of SSI. And ideally, staples should be avoided and sutures should be preferred because with staples, the rate of SSI is more. Regarding post-op phase, wound care, aseptic non-touch technique for changing or removing the dressings should be used. Wound cleansing with sterile saline for up to 48 hours after the surgery is recommended, and you can recommend the patient to take shower after 48 hours. And in case the wound is separated or surgically opened, then you have to drain the pus. In those cases, you can use tap water to clean it after 48 hours. And prolonging the use of prophylactic antibiotics in the post-operative phase for the purpose of reducing SSI is not recommended. So this was all about how you manage in intra-op, pre-op and post-op period in order to reduce the risk of SSI. The next topic that we will be covering today is post-op ileus. So if a patient presents with severe constipation and intolerance of oral intake due to non-mechanical causes after post-surgery, it is called post-op ileus. It may be a normal physiological response to abdominal surgery, but may also occur in patients after other forms of surgery, that is non-gynecological surgeries. Incidence in gynecological procedure is quite high, it is around 10 to 15%. And depending on whether it is upper GI or lower GI, the symptoms might vary. Like in upper GI ileus, the patient might present with distension, vomiting, intolerance of oral fluid intake with preservation of flatus. However, in lower GI ileus, patients usually tolerate oral feeds. However, there is absence of flatus and mild distension may be there. Now, how do you manage? So you have to do a conservative management in these cases with IV fluid replacement, antiemetics and limitation of oral intake. In case there is significant distension with intractable vomiting, you can consider inserting nasogastric tube. Ideally, you should avoid opiate analgesics in the post-op period because they further impede the bowel function. And in all these patients, you have to assess the renal function and the electrolytes. They should be checked and corrected. Now, suppose such a patient fails to improve with conservative measures, then you have to do an X-ray to confirm the diagnosis. You can get various X-ray pictures. Like the first case, as you can see here, there is distension of both large loops as well as small loops. So, gas is present throughout the abdomen, including both large and small bowel loops, and this is highly suggestive of paralytic ileus. The second X-ray finding could be like this, where you can see only the small bowel loops dilated and distended. So this is a characteristic case of obstruction, mechanical obstruction. Then the third could be where you see the cecal or the large bowel only distended. So this is a case of Ogilvie syndrome. So what is Ogilvie syndrome, which is also called as acute colonic pseudo-obstruction after cesarean section? So it is acute large bowel obstruction without any mechanical cause. It can occur in any patients undergoing surgery. It is due to an imbalance in the autonomic innervation of the distal colon, leading to atony and subsequent proximal dilatation. During a cesarean section, Ogilvie syndrome may be caused by damage to the sacral parasympathetic nerve supply, which runs close to cervix, vagina, and broad ligament. The classical presentation includes progressive abdominal distension, which is initially painless, varying degrees of constipation, and as the cecum becomes more dilated, the pain worsens, localizing to the right hand side. It may be associated with tachycardia, and eventually there is cecal ischemia, perforation, and peritonitis. Now, how do you manage these patients? Management basically depends on how much the cecum is dilated. If it is less than 10 to 12 centimeter, then you can do conservative management with consideration of IV neostigmine. And in case it is more than that, then you have to do urgent colonic decompression with a rectal flatus tube. If the decompression fails or there is evidence of peritonitis, then you should immediately consider laparotomy and bowel resection. Now, this is an important flow chart summarizing the management of Ogilvie syndrome. Again, a very important exam tested question. So, if a patient presents with symptoms of acute colonic pseudo-obstruction, you always have to consider the risk factors like emergency section, postpartum hemorrhage, multiple pregnancy, general anesthetic, opiate analgesia, or cesarean hysterectomy. And then you have to look for the signs of severe ACPO, which include if there is peritonitic abdomen, there is lactic acidosis, or signs indicative of septic shock. In case these three findings are there, you immediately go for surgical management. You resuscitate the patient, request an urgent senior obstetric, surgical and anesthetic review, perform the baseline bloods, and proceed to the theatre for the laparotomy as necessary. In case these severe symptoms are not there, then you can consider sending bloods like full blood count, urea and electrolytes, CRP and lactate to order an abdominal and the chest x-ray. And if on the reports you find the lactate more than 2 or air under the diaphragm, which indicates peritonitis, or cecal diameter more than 9 cm, again you have to go for basic resuscitation followed by rhipeotomy. Then in case these symptoms are not there, these signs are not there, then you can consider conservative measures for 24 to 48 hours. You keep the patient nilbur oral and insert the NG tube, correct the electrolytes, monitor fluid balance, and consider urinary catheter. Ask the patient to mobilize, and in case there is improvement, you continue the same. In case there is no improvement, again you have to consider going for resuscitation and laparotomy. So this is a basic summary of how you manage Ogilvie syndrome or acute colonic fluid obstruction. Then the next topic that we will be covering today is related to the nerve injuries associated with gynecological and obstetric neurological injuries. So there are 3 types of nerve injury. The first one is neuropraxia, which is basically just the external nerve compression, and usually in this recovery is fast, within weeks to months. The second is exontemesis, where there is severe compression with axon damage. In this, recovery might take longer, usually several months. And the third one is neurontemesis, where the nerve is completely transected with the damage to the Schwann cells. And in this case, there is poor prognosis without restorative surgery. Now, these are the various summary of the lumbosacral plexus injury which can occur. The first one is femoral. Femoral, you always have to remember about the sensory and the motor nerve supply of the nerves, and then you will be able to analyze for yourself what would be the clinical presentation be. So like in femoral nerve, it gives the sensory supply to the anterior medial thigh and the medial aspect of the calf. Motor function involve hip flexion, adduction and knee extension. So these movements are very important for climbing the stairs. So in this case, the patient will face difficulty in climbing stairs. So they will characteristically give you this buzzword. The patient was placed in lithotomy position for a long time, because that's a mechanism where there can be a kinking of the femoral nerve under the inguinal ligament if there is this prolonged lithotomy position, and it can cause femoral nerve injury and the patient can present with difficulty in climbing the stairs. The second is obturator nerve. Obturator nerve supplies upper medial thigh and is responsible for thigh adduction. And if it is affected, then there is only minor ambulatory problems. Then sciatic. We have 2 divisions, common peroneal nerve and tibial nerve. Common peroneal nerve, we all know it is responsible for the dorsiflexion and eversion of the foot. And in case it is damaged, it will result, this dorsiflexion and eversion cannot occur, rather foot drop occurs. So this is again an important exam tested question, that foot drop is associated with common peroneal nerve. Then these 4 nerves, iliohypogastric, ilioinguinal, pudendal, lateral cutaneous and genitofemoral, all these do not have any motor function, they only have sensory function. So you have to remember which sensory area they supply, and in case they're damaged, it causes pain and paresthesia over that respective area. Like for example, iliohypogastric nerve, it supplies mons, lateral labia, upper inner thigh, and if it is damaged, it causes sharp burning pain radiating from the incision side to mons, labia or thigh. Similarly, lateral cutaneous nerve, it supplies anterior posterolateral thigh, and it will again cause pain paresthesia over antero-posterolateral thigh, and this condition is also called as meralgia paresthetic. Genitofemoral nerve similarly supplies labia and the femoral triangle, and if it is damaged, it causes pain paresthesia over labia and femoral triangle. So it is easy table to remember, just you have to make sure you read it at the end, just before going to the exam, so that you know these important buzzwords. Then about the brachial plexus injury. So the first one is the ulnar nerve. Ulnar nerve basically supplies the small muscles of the hand. and sensory supply is given to medial 1.5 fingers, and it causes ulnar claw hand. Unlike clump case paralysis, which also arises from CAT1 roots, but in this complete claw hand occurs because it also affects the forearm muscles, and the main mechanism of injury in this is hyperabduction injury, which could be during difficult, when you pull the arm during difficult childbirth. Radial nerve, it is responsible for the extension of the wrist and the finger, and in case it is damaged, it will cause wrist drop. There is another important entity called Erb's palsy, which occurs when there is damage to C5 to C6 roots, and these roots are responsible for abduction at the shoulder joint, flexion of the elbow, and supination. And in case it is damaged, it will cause the shoulder is adducted and medially rotated, arm is extended, forearm is pronated, and wrist is flexed. So this is also called as Bater's step. And the most common cause of Erb's palsy is excessive lateral traction or stretching of the baby's head and neck in opposite direction during delivery, usually associated with shoulder dystocia. Now coming over to the next topic that we will be discussing today is on enhanced recovery program. So for the enhanced recovery program, the basic care, it starts from when the patient is referred from the primary care. So once you have decided the patient for the surgery in the OPD, your steps for enhanced recovery starts from there. What will you do? You will optimize the preoperative patient's hemoglobin levels. In case there are comorbidities like diabetes, hypertension, you try to correct them. Then in the preoperative period, you optimize the health and the medical condition, take an informed decision making or informed consent. Pre-op health and risk assessment should be done. Patient information and expectations should be managed, and in the pre-op period only, the discharge plan should be made. Pre-operative therapy instructions should be given as appropriate. Patient should be admitted on the same day. You should optimize adequate fluid hydration. So nowadays, the concept of keeping the patient NPO for long is gone. Ideally, for liquids nowadays, the recommendation is you just maintain 2 hours of fasting prior to the anesthetic, and you should ideally go for carbohydrate loading. You give complex carbohydrate drinks which have been shown to reduce the length of the hospital stay and is usually liked by the patients. Should reduce the periods of starvation, and there should be no or reduced oral bowel preparation. Then regarding intraoperative period, ideally it should be a minimally invasive surgery. You should use transverse incision. External tubings like nasogastric tube should be avoided. You should ideally use regional blocks, epidural for adequate pain management, optimize the fluid management, and individualize goal-directed fluid therapy. Then in the post-operative period, you should plan for adequate mobilization, rapid hydration and nourishment, appropriate IV therapy. Ideally, you should not put any wound drains, no nasogastric tube. Catheters ideally should be removed early, and regular oral analgesia in the form of paracetamol and NSAIDs should be given. Opiates you should ideally avoid because they cause sedation. Then discharge plan should be like once the criteria for discharge are met, you should plan for discharge, and in case there is stoma, you should teach them stoma care and provide them adequate physiotherapy if required. And post discharge also you should arrange a 24-hour telephonic follow-up. So this was briefly about the enhanced recovery program, and this was all about the basic important points on the topic on post-op care module. Thank you so much for your time.